Hello, and welcome to the Scoliosis Dialogues, the official podcast of the Scoliosis Research Society. I am Stephanie Ihnow, a pediatric orthopedic surgeon at the University of Florida in Gainesville. Today, I have the privilege of having Dr. Charlie Johnston from Texas Scottish Rite Hospital in Dallas, Texas, on the podcast. Dr. Johnston, welcome. Can you please tell us a little bit about yourself?
Well, I'm currently in emeritus status because I retired from patient care in 2022 uh, after 38 years of practice in Dallas. So I really, my entire career in ped ortho is pretty much there. Um, And the part I like the best to talk about is all of the fellows that I've had a part in training and mentoring over all those years. It approaches 200 fellows. So that's the part of my practice or my career that I'm most proud of.
It's
So,
a huge impact you've had on our specialty, especially in spine care. So that's really amazing.
well, thank you.
Today we're going to be discussing your most recent article from the Spine Deformity Journal. It's titled Traditional versus Magnetic Controlled Growth Rods for Early Onset Scoliosis Treatment, looking at radiographic, pulmonary, and quality of life outcomes at graduation. This can be a very difficult group of patients that I feel like we're still looking for the holy grail when it comes to treating them. And this was a single center study that included 51 patients, but was a very good comparison of TGRs versus magic rods in terms of their outcomes. And I think what was the most interesting, or one of the interesting things was that at the final definitive point was some patients maintained their rods after lengthening, and then some went on to have definitive fusions. But I guess first, can you just give us a little bit of an overview of these two types of growing rods?
Well, the traditional growing rods have been around since the 90s. It was originally published and worked out by Baruzek Barnia, Rick McCarthy, George Thompson, um, and it performed moderately well uh, over quite a long period of time, but always had the drawback that you had to take the patient back to surgery to lengthen the rods. And of course, there were many revisions necessary because of complications that some were due to our lack of knowledge about how to actually treat many of the patients, particularly the ones with neuromuscular or syndromic diagnoses. And some of the complications were just inherent to the biomechanical awkwardness, shall we say, of distracting a spine in a straight line when, there are two major curves in the sagittal plane that have to be dealt with. And so the TGR concept of pure distraction was kind of biomechanically invalid to begin with. Uh, that notwithstanding, in 2016, the magnetic rods became available. And while their basic concept was no different, and so you really couldn't expect there to be a great change in the outcomes of things like proximal or distal junctional problems, the rest of the sagittal discrepancies that are well known. Um, Everyone was pretty excited about it because this device could be lengthened in clinic without anesthesia. And so, therefore, was going to remove a lot of the complications and the psychosocial stresses. And so, it was the greatest thing since sliced bread.
Mhm.
at that time. Um, and our study that you were going to talk about, I guess, really compares the two, but you have to understand that they're two different epochs, as it were, epochs of time, because when the magic rods were introduced, the amount of traditional growing rods being performed dropped drastically.
Mhm.
So basically, the TGR cases that are in our paper were done prior to 2016,
Mhm.
and
Yeah.
the MCGR cases are done since that time. And so you think you're comparing them directly, but really they're sort of different because they come from different time periods.
Yeah.
So that's what I would say is the background. And the idea was that these are the two most common methods of non-fusion treatment for EOS, and the number of studies that directly compare them are very, very few. And so that was the background for the paper. That's what we wanted to do.
Y- Your hypothesis that you stated was that the TGRs would actually be more efficient in regards to increasing spine length. So more efficient really in lengthenings, and maintain or have better curve correction over time. What observations in your practice that led you to this hypothesis?
Well, again, the techniques are on the surface appear the same, but in fact, the differences in technique probably explain a lot of the differences that people have perhaps noticed between the results, and in particularly the length difference.
Hmm.
So when we take a patient to the operating room to surgically lengthen the rods, it's fairly common to kind of push it as hard as you can. We want to try to get as much length out of that anesthetic event as possible, because we know that we're only going to have a finite number of times we're going to come back. And so the idea is, get the biggest bang for your buck. On the other hand, the MCGR lengthenings in clinic were often done in a very gentle and, shall we say, conservative way, because we found anecdotally, and I think this is pretty universally true, a lot of the patients really don't tolerate it very well when they're awake. They are scared. There is some discomfort from putting the actuator on it's this big machine, that you put on their back. And so in order to try to not disturb the patients and make it so that you couldn't lengthen them at all. And anecdotally, I had several patients that you had sort of one chance to lengthen them. And if they didn't like it, the episode was over. They were very irritable, crying. Parents wouldn't allow continued treatment. So the difference is that the TGRs were pushed very hard, mechanically get
Hmm.
as much distraction as possible. And the magic, by virtue of the discomfort that was never really predicted when it was introduced, we did it much more gently. And so as a result, the TGR cases we thought we'd probably get more lengthening out of than the magic cases. And that was before we ever encountered the stalling phenomenon that basically is the bane of existence for
Yes.
the magnetic rod.
It is a machine after all, right? And you can only control machines so much for sure. Did you have prescribed lengthening intervals for your magic rods?
We did. we initially started at 6 to 8 weeks. That turned out to be very difficult for a lot of patients. Um, Texas is a big state. We had patients that were hours away to be able to come for an outpatient visit, and the feasibility of coming once every 2 months turned out to be quite a obstacle to actually following that program. And so I think, again, the study groups and anybody who's tried to study this has been very frustrated by the fact that you really can't do this on a regular basis over an extended period of time.
Yeah, no, it's really difficult. And I think, there's the whole randomized controlled trial are now kind of, kind of switch to a little bit more of a directed trial, but looking at the lengthening intervals, because I mean, one of the thoughts with the magnetically controlled rods is that we're keeping up with growth, not just catching up with growth like we are with the TGRs. And that if you can keep up with growth, number one, maybe lower risk of pseudoarthrosis, curve stiffness with the TGR. So I think there's a lot of different factors that go into the differences that you're presenting in your paper in regards to the less spine growth. Because I think that was one of the big things with the magnetically controlled rods was that if we can lengthen these more frequently and keep up with growth, we'll get more length over time. I think you make a really good point about the awake part of it. Here at our institution, we involve child life very significantly with with the lengthenings. And that has been made it a little bit more successful for sure. But there are some kids that, yeah, they will not tolerate it. And like you said, you have like one shot. It's not like a TGR where you can go back and forth and kind of get a little length on this side and then go back to the other side. It's a lot harder to do that when the patient's awake. And I think that's really hard to quantify that how that affects the lengthening and the amount lengthened over time. So I guess we can go to kind of some of the main results that you had. So you looked at kind of four different things that you presented, which one was the radiographic and then the pulmonary quality of life outcomes as measured by EOSQ-24. And then also you looked pretty significantly at the complication profiles of both. I think let's start with kind of the radiographic outcomes because I think that's most straightforward. So you found that a couple of things about it. You looked at both the T1, T12, and then the T1, S1 height. And you found that the amount achieved with lengthenings was greater with the TGRs, but that you also stated that the final height was similar between the two groups at definitive fusion. So do you think the MCGR curves were more flexible or less through pseudoarthrosis, or what are your thoughts on at the fact that you actually in the end kind of got a similar height change?
Well, I think there was a little difference at the initial implantation, that the TGR curves were bigger, and I think their length, the spine length, was less to start with. So the improved length that we got with the TGR basically just caught it up and evened it out with the magnetic cases. Um, and the final lengths probably were also very much affected by when the final fusion was done, because many of the magnetic rods were fused when they stalled. And that may have been a much sort of shorter time period for the devices to be in place than with the TGR cases where they were in probably for a longer period of time. So the final fusions for the magnetic cases were actually fairly effective. They got better correction, better
Hmm.
cob angle
Hmm.
correction.
Yes.
And I don't know why that occurred. That, in other words, the definitive fusion for the magnetic cases was more effective, unexplained, but that's what we found. And yeah, I think you could probably postulate that it's due to the fact that the magnetic rods probably had a shorter in situ lifespan and maybe didn't have quite as much autofusion at the time of the definitive fusion.
Did you look at, so I made a little table in preparation for this, looking at the different types of scoliosis, because you did include idiopathic, congenital, syndromic, and neuromuscular. And I think the biggest difference was basically in the idiopathics, you had a significant number of, greater number of magnetically controlled kids.
Yeah,
So it was 11 versus 4 in TGRs. Neuromuscular was pretty similar, but there were definitely more syndromic kids in the TGR than the MCGR group. Do you think that affected the outcomes at all? Or did you, I mean, I know the numbers weren't huge. Were you able to look at it by type of scoliosis, or was it just not powered enough?
I don't think it was powered enough. And, this was impossible to um, kind of analyze statistically, but I'm sure that there were more TGRs in the syndromics because they were able to be contoured more precisely. The magic is very difficult to contour
Yeah.
to severe
Okay.
deformities,
Mhm.
especially, kyphosis.
Absolutely.
And therefore, I think there were probably incidences where the intention was to try to put magic in, and it simply was not feasible. And so, therefore, the default was to TGR. And that is a definite flaw in the paper, a weakness. We really had to lump them all together to have enough numbers to analyze anything of value. And the individual diagnoses are definitely a confounding fact that makes any of the conclusions suspect in a way.
I think it also, I mean, if there was more flexibility in the magnetically controlled group and they're more idiopathics, they do tend to be more
Yeah,
flexible over time. And I think it kind of explains why the curve magnitude, you got pretty significant differences between the Cobb's post-definitive fusion. I mean, 50 versus 32 is a pretty significant difference. And it might just be the patients that were in each of the groups. But yeah, I did look at that. I was looking at that, because, the index age and the age at the end of growth friendly was actually similar between the groups. And I was kind of curious about that because I feel like I was wondering if, like, around the time where magnetically controlled growing rods were coming out, did you delay a little bit waiting for them for some patients? And if that affected anything, but I mean, the ages was 7.24 for the growth friend for magnetically controlled versus 6.54 for TGRs, which wasn't statistically significant, but that is, you know, 8 to 9, 9 month difference, which in this age group actually makes a big difference. That's almost two lengthenings, right? And with TGRs. Do you think that played any part in the outcomes?
this is a retrospective.
Yeah.
Um, I don't think we can really state with any certainty that that was the intention. Um, Again, jumping ahead, knowing what we now know about both of these methods, um, I would say it was likely that the TGRs were used in younger patients because they were easy to fit in.
Hmm. Hmm.
Magic has, again, a sort of a minimal length that is available. And if the contouring and the ability to avoid, the actual actuator part, which can't be bent, uh, that's probably what explains why the age difference, that
Hmm.
the
Hmm.
older kids and the idiopathic kids are more likely to get a magnetic rod simply because of the ease of insertion and the perhaps urgency of getting started with treatment. Um,
Yeah.
we tended to, urgently treat some very young children because their curves were so big.
Yeah.
And so you
Yeah.
needed to get
Absolutely.
started on something. And, now knowing what we know now, that probably was a mistake because the earlier you start, the earlier you're done
Yeah.
because of the autofusion issues. And so nowadays, I think, the delay is pretty well accepted as the way to go with either technique.
I mean, the pendulum always swings, right? We try one thing and we go a
Well,
little earlier and then we go later and then again we're gonna come to the middle at some point. I have a feeling. I just don't know when that's gonna be. Right?
indeed.
So, your institution is really wonderful about getting PFTs. So I'd like to kind of touch about your PFT measurements and ask and those outcomes because I think it's actually really awesome that you have so much data on this because the reason why we are doing all of these procedures and surgeries is not because of the spine itself. It's really because of the lungs, right? Because we don't want to cause this restrictive lung disease in which these kids would get the bigger their curves get. So knowing how we're affecting the lung function is really why we're doing all of this intervention. So, um, I saw that. So your absolute FVC and FEV1 increased in all patients over time, probably as because they were getting older and we were making, despite the MCGRs maybe not making the chest cavity as big, all of them were increasing and getting bigger. But the percent predicted, so compared to the, age and race matched norms, did not improve with the MCGRs, but did with the TGRs despite the curve magnitude actually being a little bigger with the TGRs. What do you take from this result?
Well, again, I think you have to preface it by the data is not as clean or consistent as you'd like. The earlier patients, the administration of the PFT test was very inconsistent early on in the study. And so we had a lot of patients that had incomplete pulmonary data. And so the only way we could actually analyze it statistically was we had to lump everybody together at each of the four time frames that we were analyzing. So, pre-treatment, end of lengthening, pre-definitive,
Mhm.
lap, and final. And so the explanation for why the TGRs are better, I'm not sure I can explain, other than I think what happens with the magnetic rods is that there is probably a stalling that happens that we did not necessarily deal with well in the earlier part of the study. And I'm not sure that those pulmonary outcomes were optimized because
Mhm.
of the way that the stalling was perhaps handled. And the to give you an example, a kid would be going along getting their magic rods lengthened, and then it would stall. And we'd say, okay, come back in 2 months and we'll try it again. And still stalled. And we'd say, okay, we're going to try one more time in another couple of months. And, you're sort of kicking the can down the road. And by the time, and then you got to the point where we're losing ground
Yeah.
because basically of a crankshaft type of phenomenon. You've got a posterior device which is tethering the entire spine and it's growing in the front. So you then had lost correction and the definitive fusion was done and you got better Cobb correction, but it wasn't enough to reverse whatever pulmonary uh, trouble had happened. And again, this is speculative
Mhm.
because our pulmonary data was not consistent enough to really take an individual case and try to say, this is why it was better, or this is why it wasn't. This is all from pooled data for the entire 27 patients or whatever it was in the MAGIC. And I think that's probably all I should try to say about it because it's not clean data.
I think the promising thing is, though, that the absolute measurements did increase over time, which is a representation of an
Right.
increasing chest wall. So I think we have some positives that came out of it, which was that all the patients, as we grow them, they do increase over time. So I think that's positive news.
Well, I'm just going to point out to you that, again, now that we know what we know now, I think the emphasis on getting length was probably misguided. That we have discovered by redoing our pulmonary follow-up on a lot of patients that, it was sort of the revisiting the original Lori Carroll study that everybody quotes. Um, there's no question that we were paying way too much attention to getting length and not nearly enough attention to getting correction of the deformity, including axial plane correction. And now, I think the acceptance and the evidence on the apical control techniques is so clearly superior to what we were doing just with distraction from you know, uh, a UIV and an LIV that, this is the lesson we've learned,
Mhm.
and that our pulmonary outcomes from more and more length have ended up being, I won't say bad, but they're certainly discouraging.
I think the hardest part about studies like these or patients like these is it takes so many years to learn probably what we truly need to be doing. And at that point, we're already doing other things, and it's just so hard to keep catching up over time to know exactly what to do. That's what I find the hardest is by the time we kind of figure out how to do that, we've already kind of brushed it off and turned to something else. So, okay, so let's move on to the quality of life outcomes that you discussed. So I think again, this one kind of going back to as you discussed the pulmonary, you had a lot more of PFT measurements with your TGR patients. The EOSQ 24 didn't come out until closer to 2016, and so we also didn't, or you did not have a lot of, reliable outcome measures in your TGR patients. So you did just focus mostly on the MCGR patients due to not
Well, in
having.
fact, our ESQ report is only magnetic rods.
Yes,
We
correct.
really
Yes.
didn't have the data for the TGRs.
Yes. So, so you compared the MCGR patient group, looking at the EOSQ scores, pre and the pre-growth friendly, at the end of growth friendly, and then after definitive fusion. And interestingly enough, in contrast to what we just talked about in terms of the actual PFT measurements, these results did show that the EOSQ scores in the pulmonary domain did improve after their definitive fusion. So even though maybe their numbers objectively didn't improve, the patients or the parents felt that they were breathing better. So I think it was very interesting. I don't know if you have any comments on that note.
Well, again, my I guess gut feeling is that many of the patients report improvement when they know that they're not going to have any more operations. And
Yes.
so, again, I would take a little bit of grain of salt on the observation that their EOSQ scores for some of the domains did seem to improve at the end. Um, and this is I think I think we are still searching for an instrument to analyze outcomes that take into account things like that.
Mhm.
Um, that when a patient knows that they're still going to need to have more surgery, they're not very happy when they fill out their questionnaire in clinic. And when they know that they're done, they're a lot happier. So I think there's probably a little bit of a fudge factor in a lot of those numbers.
Yeah, because I mean, on that note, the quality of life measure was unchanged during the lengthening phase, and then, like you said, after definitive
Right.
fusion, it was much better,
It
which
was better.
is also a promising finding that, the family does see the light at the end of the tunnel one day. And it is a long process. And when I see these patients and doing all this, I always say it is a process. This is not like you're gonna come, we're gonna, if you want to call it fix this and then we're done. I mean, this is a very long process where we become very good friends and almost family sometimes, right? Where you're seeing them. I mean, my MCGR patients, I mean, I see them every couple months for sometimes a long time, and you really do become, it's a really amazing relationship you develop with them. But it's good, it's apparently they don't feel the same way about their quality of life though when they're seeing you every single time until you're done with them. So,
That's right. Well, I think we've also found, again, now that we know more because we followed them for so long, that a lot of the patients are psychologically very, um, shall we say, reluctant to come because they've been coming so much.
Mhm.
They don't really want to come to clinic, even
Yeah.
if they're just going to have, the actuator put on their back. And this is a phenomenon that we certainly are now very cognizant of. But back in, shall we say, 2018, a couple of years into the magnetic rods, we had no clue that this was happening and that the EOSQ scores or any of the other scores were um, declining because it was stressful, whether or not you were having surgery.
We see that being true though in a lot of different EOS care. I mean, we looked at the quality of life scores for bracing and casting EOS patients, and the actual cast was way harder on them than a brace. So we see this in a lot of different sectors of kind of the ups and downs of this of the process of EOS care, to be honest. I think that after definitive fusion, though, we can reassure patients and parents that there is light at the end of the tunnel, and eventually, hopefully, they end, higher than they began. I think that's really just the goals. Any other notes on quality of life or the outcomes?
No, I think we all suspect that the patients are stressed. And unfortunately, with a lot of those questionnaires, the parents are the ones that are filling it out. And so the parents may be falsely filling out scores because they want you to keep treating their child, even though they realize that the treatment is not particularly comfortable or it's not going that well psychologically. So I think, our understanding of that phenomenon now is quite good. And as you already mentioned in your clinic, having child life, and we have the psychologist is there. And this is this has developed both with the EOS program and with all of our, you know, limb reconstruction and limb lengthening clinics. Same thing. The psychologist plays a huge role in the, clinic interaction that goes on with each visit.
Absolutely. I mean, even in the neuromuscular patients or the patients that can't verbalize as much, I mean, even putting the ERC on them is a scary event for them because they can't see what you're doing and they just feel this huge jolt basically when it
Mhm.
attaches to their rod. Having somebody there that's playing music or holding them in a certain way has really changed their response, I think, for sure. So finally, we will talk a little bit about the complications. I think, there's a lot of papers that go over complications of TGRs, MCGRs, the stalls, the law of diminishing returns that actually applies to both of them. But I think the most, main finding that you found with you presented with the complications was that TGRs had more uproar than the MCGRs. So my
And that's, I think, to be expected.
It is. My only
You know that.
question with this, yeah, my only question with this is when you defined uproar in this study, one of the thoughts is that TGRs are already going back to the OR every 6 months. So were your uproar events were in between their lengthening events?
Yes.
Mm.
If there was going to be we also had a separate category for revision.
Yes.
And so if you've got a complication that you're going to revise at the scheduled 6 month interval, that's not an uproar, but it is a revision.
Hmm. Hmm.
So that's I think the important differentiation.
Yeah, I saw, yeah, and the TGRs definitely underwent more revisions. And then as you mentioned earlier, with all the MCGRs that stalled, so five of them underwent exchanges. And then I think you already alluded to it earlier. The rest of them, if they underwent stalls, you just waited or did a definitive fusion for them.
That was usually the solution, yes.
Okay.
And,
Um,
I think we now know that revision magnetic rods are not worth the squeeze. You don't get much from them
that's
on the exchange. And so I think we've arrived at that conclusion by suffering the consequences of replacing the magnetic rods and then finding that nothing much happens.
Yeah. The
I
second set definitely, I feel I agree. I mean, and things have been proven, but it's just doesn't work as well as the first. I don't know. I don't know if
exactly.
any of us know why, but per se, but
Well, I think we know why also, although it's, the distractive force on the magnetic devices is not great. And again, this is one of the reasons why the traditional rods can get more length, is that you can really push that because the patients are obviously under anesthesia. And so, I think we've realized over time that the distractive force is, shall we say, suspect in the magnetic rods, and so that's
um
why they stall.
did you include, I did not see it, but do you have an idea of a comparison of the weights of the two different groups? Because as you're alluding to, the MCGRs, the bigger kids, it just can't get the distractive forces, or the kids with the depth of the actuator has been also shown to affect
Right.
the effectiveness of the ECR or the ERC.
I think we probably have that data, uh, but we did not. It's not in this paper, and that's an oversight. We might have added that. Uh, we certainly have cases where, as you just alluded to, where we can't make the actuator work because there's too much distance between the skin and the magnet
Yeah,
in our fluffy patients. So,
yeah, agree. Okay, I was just curious about that. So I guess to kind of the one other thing that I was going to point out, and you kind of mentioned it earlier also was the crankshaft. You only saw crankshaft in the MCGR group, not the TGR group, which I think it was described more with fusions. I guess do you have anything to say about that or?
um, only that, again, I think the TGR patients were stretched as far as they could go for the reasons that we've already mentioned. And the MCGR patients were lengthened gently.
Mhm.
And I think we had many instances, especially early on in the program, where we were taking a lot of x-rays or we were trying to show the length that we were getting with ultrasound.
Mhm.
And the fact is that the length of the device was not um, measurable in terms of lengthening the actual spine. And this was well known, I think, from the group in Oxford way back, Colin Yachty and them had noticed that you could lengthen the magic rod a centimeter and you could lengthen the spine, um, maybe 3 or 4 millimeters. It was less than half, it was pretty striking. And so all I can say is that if you have a rod in that you think you're lengthening
Yeah.
and it's not really doing much to the spine, then the spine's growing in the front and that's how it crankshafts.
It's doing something somewhere, right?
Yes.
Just
And I
not where you
think
want it to happen.
we realize that
Yeah.
probably too late, too often. And so that the deformity had actually gotten a whole lot worse with the magnetic rods in terms of rib hump and crankshaft and axial plane deformity, because we weren't really getting that much spine length.
Yeah. I mean, it's a long, rigid structure that we're putting in the back of the spine. And as you said, you can't contour it in those areas. And I think in the earlier years also, um, we were trying to fit them in, right? I mean, and try to fit in the biggest. There's the 70s versus the 90s of the current device that we have. And you would think that the bigger it is, you got a lot more length out of it per se, right? Potential length out of it. And I think that also, but trying to fit in the bigger one also decreased the amount of uh, contouring we could do of the rod, and that might have also affected things. So there's so many different intricacies to the rod. I feel like that can contribute to things.
Well, I think, we've learned a lot about it. And I would venture to say that the indications for magnetic rods has changed fairly significantly over the years to the point where now really we only use it around here for the low tone, flexible, possibly neuromuscular patients. Um, it's rarely used for the JIS group.
Hmm.
Um,
Hmm.
it probably has little or no use in a congenital group. So, and this is all the school of hard knocks.
Yeah.
We've learned by the mistakes. And as a result, I think the use of magnetic rods has changed appropriately so that we now know who it works for and who it's probably not going to be of much benefit. And that goes really for, um, I don't know if I should editorialize here, but that goes really for any growth sparing treatment now. We're
Yeah.
pretty well, you know, down the road that we know that we're not making them significantly better. Um, we've got several series that shows that the amount of improvement is minimal to none. That was one of the papers that that I was going to talk about with you before I found out that we were talking about this one. Um, that
Yeah.
the benefit of the growing systems over a definitive one and done fusion is hard to show.
Yeah.
We don't have that data to show that.
I
So that's
think
my
that
editorial.
no, that's a great conclusion. And I think you really went through how this has changed. I know you're not practicing officially anymore, but how you think of these patients and these different growth friendly techniques. And I am trying to figure out if I am uplifted or not based on everything at the end of this when we keep trying really hard to find new things, and it seems that we kind of keep going back to the old fashioned, if you want to call it that, fusion. um, to have the most reliable, predictable results and possibly the better outcomes. So I'm just trying to figure out how I feel now about all this.
Well, it actually, there's probably a place now to redefine what EOS really is. Because I think that it's clear that for the average child 8 years and older, we don't have a good indication for fusionless distraction. And if you're going to be doing anything like that, it should be with apical control and great attention to correcting the three-dimensional deformity rather than pushing for length,
Yeah.
because the additional length does not appear to give any benefit
So
over what you
I,
can
I'm
get
sorry.
with a one and done fusion. Well done.
I am gonna completely say something a little bit off topic, but not really, which is something I've been thinking about a lot, and I that I always say is that age is just a number, and that is one of the biggest flaws I think of how we think about some of these kids. Is not all 8, 9, even 10-year-olds are the same. And so when you're talking and stating about redefining even what EOS is, is it based on skeletal growth then? Do we need to go back and think about that versus just age, which is just a number?
You're right. And that kind of deep dive into how much growth is remaining and what we might achieve with just a single definitive fusion are things I think that are being worked out right now. Um, and, it'll be another 10 years, I fear, that before we know, the real answer on whether any growth sparing treatment is appropriate in a child who has a certain length of spine. And
Absolutely.
that's the number that we need to find.
Yeah.
What
I
is
mean,
what's
yeah.
that number?
I mean, the Sanders system, scoring system was not that prominent way before when the study started, probably, right? Or I mean, it's retrospective when you did all these early, like the TGR patients, but I mean, it makes a huge impact when you get that bone age and you get that Sanders score. It can change your discussion, right? Like if you look at a single curve, don't look at any of the skeletal maturity markers and then you get the skeletal maturity markers, it can have a very different impact on the conversation you're having, right? Or a very different conversation that you have with your patients and the family. So, um, but we still, so many of our, what we focus on is age a little bit, I
True.
guess I should
And
say, a
like
little
I
bit.
said, I think what
But
we need to know
we're
is
evolving. We're evolving, I think.
what is the length of spine that we need to have along with three-dimensional
Yeah,
deformity
absolutely.
correction.
Yeah, absolutely.
And when we know that, then I think we'll be finding that the patients who actually need growth sparing surgery are much younger than what we're doing right now.
Hence the pendulum swinging back the other way.
Mhm.
Yeah.
Yes,
Yeah. No, I mean it's EOS is a very complex disorder that the I mean I love it. I think it's very rewarding, but it's very, very difficult. Very difficult to treat.
I won't disagree with you, and I'll just say that as you spend more and more time treating these patients, you find that you're taking more and more antacids and other medicines to try to calm your nerves and your stomach and everything else. So,
Oh yeah. They are so yes. I could go on and on about that and the stress
sure.
that they
Well,
have brought to my life.
the challenges are well known,
They
and
are. They are.
we've got to do better if we can.
Yeah. Okay. Very good. Well, I will leave it at that. I really appreciate you joining us today. Fabulous job with and conversation. I think we went way beyond what the article actually,
We
the
did.
complete context of the
if
article,
that's appropriate.
but it's always nice to talk to somebody who's so experienced in this and has gone through all of the different iterations and trials to try to treat these kids the best we can.
Couldn't agree more. And I thank you for inviting me because this is fun to do, and always um, discussions like this are quite, constructive.
Yeah. Well, I appreciate it. It was good to see you again. Thank you, everyone, for listening. Again, Dr. Charlie Johnston from Emeritus at Texas Scottish Rite Hospital in Dallas. Again, we talked about the traditional versus magnetic controlled growing rods, and I appreciate everybody listening today.